Hello and welcome to this lecture on pharmacokinetics. Usually we talk about pharmacokinetics as what the drug, what the body does to the drug, and pharmacodynamics, what the drug does to the body. Okay, so pharmacokinetics is what the body does to the drug, how the body is actually going to take the drug in, break it down, distribute it, and how the body is going to utilize it. These are layman's definitions, and as we go through this lecture, we'll really think about pharmacokinetics as the process that begins with absorption, distribution, goes to metabolism, elimination, and also toxicity. Okay, so let's get ready with this. Let's get ready to start this lecture here. All right. So there are many different factors that affect whether a drug is going to reach its target. So the fact that a drug is active in vitro doesn't mean that it's going to be active in vivo. The fact that a drug is potent at its target site doesn't mean that it's actually going to be useful clinically. That drug actually has to be able to be absorbed, distributed in the body, and then reach its target. So drug design needs to consider not only binding interaction but also pharmacokinetic parameters. Okay, so when we talk about pharmacokinetic parameters, we have drug absorption, drug distribution, drug metabolism, drug excretion. Okay, and there's also toxicity. All of these different factors here are going to be influenced. They're all going to be influenced by the chemical structure of the drug, okay, by the chemical structure of the drug, and they're also going to be influenced by the route of administration. So let's begin with drug absorption. Okay, now a drug can be taken many different ways. You can take a drug by mouth, which is one of the most common way. You can also administer a drug parenterally, meaning with a syringe, injecting it with a needle. You can take the drug rectally, dermally. Um, those of you that are used to taking an inhaler for respiratory issues such as asthma, you can take drugs through the lungs. So there's many different ways you can take drugs. When the drug is taken orally, it has to cross the gut wall to reach the blood supply. Once that drug gets into the gut wall, once it gets inside of the GI tract, it doesn't have to, once it gets inside of the cells, not only does it have to get through the cell lining, but there are also gaps between the lining of the GI tract, between the cells of the GI tract through which the drug can actually pass through. Okay, so there's two different things. Not only does it have to cross the cell linings, but it can also cross in between. There's gaps between the cells where the drug can seep through. So drugs are required to have a certain balance between hydrophobic and hydrophilic characters. If they're too hydrophilic, they will not be able to be absorbed by the body. If they're too hydrophobic, they become they can be too big. Maybe they don't dissolve well. So you have to strike a good balance between hydrophilicity and hydrophobicity. Okay. Now there is a rule of five that Lipinski came up with, and although we call it a rule of five, there are really guidelines that can help us understand how orally active drugs, or what orally active drugs are supposed to look like. And these are guidelines. There are many exceptions to these guidelines, but at least they give us a foundational understanding to begin drug design. When the drug is too polar, that drug can be administered by injection. And I also want to say when a drug is really fatty, that drug can also be administered subcutaneously under the skin and goes right there under the skin and can then disperse through the fat cells into the rest of the body. Now, when a drug is really polar, although it may not be able to cross the cells, what it can do, it can actually stay inside of the gut. And there are some antibiotics that are administered that are very polar that are not going to be absorbed or distributed in the body. But if you are targeting a GI type of infection, those drugs can actually be used inside of the gut. So the Lipinski rule of five these are guidelines that give you a general overview of the balance that drugs are supposed to track between hydrophilic and hydrophobic properties. And drugs have to obey at least three of the following rules. A molecular weight has to be less than 500, no more than 5 hydrogen bonding donor groups, no more than 10 hydrogen bonding acceptor. So no more than 500 hydrogen bond donors, no more than 10 hydrogen bond acceptors. A log of P has to be less than 5. But it's not foolproof. There are many different exceptions. And as I mentioned earlier, they're really just guidelines. So you have some small polar molecules that, as I was mentioning, can cross the gut wall through small pores between the cells. Okay. You also have some polar molecules that can be carried across by transport proteins. Lisinopril, for instance, is an ACE inhibitor that can be transported across the cell membrane by transport proteins. Now, the way transport proteins work, the drug comes, the transport protein is lining the whole surface here, as you can see, and there is a place that the drug can interact with. It comes in and it attaches to the transport protein. The transport protein takes the drug and carries it all the way into the cell. The cell never really crosses the cell membrane. The drug never really crosses the cell membrane itself. It's simply carried inside of the cell by the transport protein. Another way that can allow drugs to come into the cell is a process called pinocytosis. It allows the passage of large polar groups into the cell without actually crossing the cell membrane. So in pinocytosis, the drug comes in and there is a the shape of the cell membrane changes so that there is a formation of it forms a hole inside of the cell membrane that allows the drug to penetrate, and then the drug actually goes inside of the cell with a layer of the lipid bilayer around it. Then the drug is released into the cell. The drug can also pass through the cell and go out the same way it came in. So that's an exception to the regular. These types of drug will not have to abide by the Lipinski rule of 5 and can get inside of the cell that way, either through transport or through pinocytosis. Weber gave us another list of parameters, and in his analysis, he mentioned that molecular flexibility is actually very important to drug absorption. And the Weber parameters really take out of the equation the molecular weight. So too many rotatable bonds is bad for absorption. The polar surface of the molecule also plays a role. As I mentioned, molecular weight is not a factor in here. So the total hydrogen bond donors and hydrogen bond acceptors has to be less than or equal to 12, and the total number of rotatable bonds has to be less than or equal to 10. Now, the higher the flexibility, the lower the absorption. Okay. Now, when we talk about rotatable bond, we only take into considerations bonds that actually will affect the overall conformation of the drug. Okay. Not all of them are taken into consideration. I'll show you a picture of that in a little bit. Now, the polar surface area has to be less than 140 Armstrong, and the number of rotatable bonds less than or equal to 10. So either one of these clauses here have to be respected for the Weber's parameters. Again, I mentioned that not all rotatable bonds are counted when we look at the Weber's parameters, and only the bonds that lead to significant change in conformation are going to be changed. Now, if you have a bond such as in the amides, with a partial double bond character. Those bonds are not included because obviously there is limited rotation around these bonds. Okay, so when you look at this structure here, there are many different bonds that can, where there's many different possible rotatable bonds, but only the bonds that will actually yield a major different conformation of the drug are accounted by the Weber's parameters. So the bonds in red are going to be the ones that will be taken into consideration. So let's jump into distribution here. Once the drug gets inside of the gut wall, the drug is then going to enter the blood vessels. Okay, so the lining of the blood vessels are loose fitting. So there is no need for the drug to cross the cell membrane there. They can simply seep into the blood vessels. Now the drug can quickly cross the blood vessels. Quickly cross into the blood vessels through the pores between the cells, and when the drug is absorbed orally, it's going to be taken to the liver. It's taken to the liver, and there is an effect called the first pass effect. So when the drug is taken in, even if it's no matter what the dose is, it has to go through the liver. Once it goes through the liver can deactivate the drug, metabolize the drug, and not all the dose that was given is actually going to be able to affect the cells, the targeted cells. So modifications are possible by the enzymes that are in the liver. Okay. So again, first pass effect has to deal with not all the drugs that are absorbed, not all the drugs that are administered are actually going to be distributed in the body. Sometimes the liver is going to deactivate the drug. Sometimes it's actually going to activate it, especially for drugs that are administered as prodrugs. Within 1 minute of absorption, the drug is usually evenly distributed within the blood supply. Now, there's a few things that can cause uneven distribution of the drug in the blood supply. A few things that can cause that. One of these things can be, for instance, if a drug is actually going to bind to, if a drug is going to bind to macromolecules, or if a drug is going to be stored inside of fatty tissues or inside of the bone. So that will disturb or disrupt distribution of that drug. Sometimes you have rapid distribution because the blood vessels can be leaky and leak that drug into the rest of the body. So it's important to remember that even if the drug is inside of the blood, it still has to enter the target cell that it is targeting and produce the effect that's desired. Now, when it comes to the brain has tighter fittings between the cell lines, the cell that line the capillaries in the brain. So you don't have, it's harder for the drugs to cross the blood-brain barrier, and the capillaries that are lining the capillaries in the brain have a coating of fat cells as well. So it makes it more difficult for drugs to cross that blood-brain barrier. It is easier for drugs that are bulkier, more hydrophobic to cross the blood-brain barrier than for hydrophilic drugs to cross the blood-brain barrier. So one of the ways to prevent drugs from having CNS side effect is by increasing the polarity of these drugs. When you increase the polarity, you reduce CNS side effects. The placenta is also a barrier. Some drugs can get through the placenta and others are not able to. And drugs are ranked based on the ability to cross the placenta on you have what we call the AB ratings, and whether or not the drug is safe enough to go inside of the placenta or not. So some drugs are teratogenic, so the mother cannot take it because it's going to affect the health of the child, and some drugs simply do not cross the blood-brain barrier, the placental barrier, so they're safe to be taken during pregnancy. Now, quick note here on drug metabolism. Anything that's taken in the body, any chemical, is looked at it as a xenobiotic. It's looked at as something that is a foreign entity that needs to be detoxified. The liver is the main site of metabolism. However, there are other places such as the lungs where metabolism can take place, and also the skin where metabolism can take place. The blood, gut wall, and other organs are also there. Now, metabolites are the product of drug metabolism, and then, as I mentioned, sometimes metabolites can be more active than the drug itself, but most times they are actually less active or inactive. The way structure is modified through metabolism can then interfere or prevent binding interaction with a particular target. I also want to mention that if two drugs are metabolized by the same enzyme, they could also have some drug interactions going on there. So we mentioned before, orally absorbed drugs have to pass through the liver before distribution to the rest of the body, and then only a percentage of the orally absorbed drug is actually going to be able to get to its target. Most of it, some of it is going to be metabolized prior to distribution, and that's what we call the first pass effect. Now, when drugs are administered using either the lungs or through injection or rectally, they can actually avoid the first pass effect. So you can get a higher dose inside of the body without going through the liver. Now, it's good and bad. It's good because if you are targeting a systemic type of infection or a systemic issue that you need to treat right away, you can inject the product, the drug, it goes in and it treats it. It's bad when that particular drug that you've injected has toxicity. At that point, you haven't given the liver a chance to detoxify it or to metabolize it, and so the toxicity is going to be, the risk of toxicity is going to be higher when you have drugs that never go through the first pass effect. And again, a percentage of these drugs that are non-orally absorbed will not be able to reach the liver. Some of it is going to stay in the fat cells. Some of it is going to go to specific tissues. Now, it's not a bad thing if a drug can be stored inside of fat cells and then be released over time, especially if you're trying to have a drug that is only administered once a month. Let's say you have a schizophrenic patient, then you don't necessarily want them to have to administer a drug every single day. Or you have a patient that's older that forgets to take the medication. Having a drug that stays in the fat and is released later on during the day or the week allows you to have less allows you to have a higher dosing interval and less individual doses that the patient has to take. Now, when we talk about metabolism, we talk about phase 1 and phase 2. Metabolism has to do with making a drug more hydrophilic so that it can be excreted by the kidney. Okay, so that's the purpose of metabolism. So metabolism has to be defined as phase 1 or phase 2. Phase 1 reactions are oxidation or reduction reactions. Phase 2 usually are conjugation type of reaction. So the phase 1 is going to add a polar handle to make it more polar. Okay, and the phase 2, as I mentioned, they're going to be conjugation type of reaction. All these to help the drug be eliminated through the kidneys. So the goal is to increase the polarity, and increasing the polarity is going to lead to increased excretion of that drug. The main enzymes that take care of metabolism are the cytochrome P450 enzymes, and they deal with the phase 1 oxidations. All right, so cytochrome P450 enzymes are located in the liver. There are different families in human biochemistry, and they differ in type of individuals. not only do the families have differences within themselves, but also individuals have individual differences in cytochrome P450 enzyme that are present. So those differences lead to patient variability, which can sometimes complicate drug levels and lead to different results. Two different patients taking the same drugs can have different results because those drugs are metabolized differently in the liver. Okay. Now, there are some drugs that can actually induce some cytochrome P450 enzymes. So if those drugs are taken concurrently with other drugs that are also supposed to be metabolized by the cytochrome P450 enzymes, it can lead to changes and alteration in the pharmacokinetic parameters of those drugs. All right, so quickly going through the phase 1 reactions here. Oxidations catalyzed by the cytochrome P450s. You can have oxidation of exposed alkyl groups, as we can see in here. You can also have oxidation of alkenes and aromatic rings forming here of an epoxide. I want to stop right here and mention the fact that it is possible that these can, we've talked about alkylation before. So when you have an epoxide like this, it is possible that if you have nucleophilic groups in the body, the proteins and so on and so forth, you can actually have some of these proteins or nucleic acids alkylate to these metabolites and form some damaged product inside of the body. So these are some things that you need to remember as well. So oxidation of alkenes and aromatic rings are possible. You also have oxidations of N-alkyl groups, okay? N-alkyl groups, where you can have demethylation, for instance. Demethylation. So this here has a methyl group, and the methyl group has been removed here. Continuing with the phase 1 metabolism, you can have reduction of nitro, azo, and carbonyl groups. Okay, nitro groups giving you the amine here. Azo group giving you these two amines, and then the carbonyl groups giving you the alcohol there. You can also see hydrolysis of esters and amides, and all these reactions are taking place are being carried out by the cytochrome P450 enzymes. So hydrolysis of esters and amides are possible as well. As we continue on here with the metabolism, phase 2 has to deal with I feel like I may have skipped. Okay, we're good. Phase 2 has to deal with conjugation reactions. You can have glucuronide conjugates, okay, in the presence of UDP glucuronate. So you can have glucuronidation taking place. You can also have sulfation taking place, where a sulfate group is added to a group to make sure that the compound is actually going to be excreted. And there are other types of conjugation that take place, and we will have an entire lecture focused on metabolism soon. Glutathione conjugates are also possible. Glutathione conjugates are possible, and once the glutathione conjugates are generated by the body, then they can break down to generate the mercaptopuric acid conjugate. Methylation and acetylation are also seen in phase 2 reaction. S-adenosyl methionine is responsible for methylation, and you can also have acetyl-CoA that's used for acetylation of molecules. Now I mentioned drug-drug interactions, so quickly here going through some of the well-known, and I don't think it's written here, but ritonavir is another drug that we need to keep in mind. But you can have drugs that enhance the activity of cytochrome P450s. There's other drugs that inhibit the activity of the cytochrome P450s. So when you have those drugs that are taken in combination with drugs such as warfarin and other drugs, you have to be very careful of the dosing, especially with drugs such as warfarin that have to be within a certain therapeutic dosing. Okay, it can either result in overdose or underdose. If a patient has an overdose of warfarin, they can bleed to death. If they don't have enough of it, they can have blood clots. So it's important to remember when drugs are administered together that some of them can increase the activity or inhibit the activity of these cytochrome P450 enzymes. You can also have drug-food interaction. One of the most famous drug-food interaction is grapefruit juice. Okay, grapefruit juice that inhibits the activity of cytochrome P450 enzyme. There is a particular not antibiotic, antihistamine, terfenadine. Terfenadine metabolism was terfenadine metabolism actually was is goes through the cytochrome P450 enzymes. In the presence of grapefruit juice, the metabolism is slowed, and that leads to a buildup of terfenadine, which leads to cardiac arrest. So, fexofenadine, which is an analog of terfenadine, is actually preferred because it has less side effect than terfenadine. So, drinking grapefruit juice inhibits cytochrome P450 enzyme, builds up terfenadine in the body, which can lead to cardiac toxicity. So that can be very significant. And then Brussels sprouts, and cigarette smoke can enhance the activity of cytochrome P450 enzymes. So when we talk about drug excretion, the main route is going to be the kidneys, but there are other places. The lungs, you have the skin, through sweat, breast milk for nicotine. So when mothers smoke and breastfeed, their babies are also taking in some of the nicotine. Morphine is going to go out through the bile duct, and the kidneys are the major route of excretion. Now the kidneys are I'm not going to give you a biology lesson here, but just a quick illustration. It's what the kidneys look like. The blood is going to be filtered. Since I'm talking about blood, let me change the pen here to red. All right, so blood is going to be filtered here. Goes here, filtered through the glomerulus, and the water and some of the components gets in the nephron. Okay, water gets in the nephron. Now, so the blood comes through here, water gets in here with some of the components that are inside of the water. Okay, now at different places here in the tubule, okay, at different places in the tubule, water is going to be reabsorbed as well as some other so water is going to be reabsorbed as well as some other components such as sodium and some of the minerals. Some of it is going to be reabsorbed back. Okay, sometimes through different pumps, through different transporters, and so a concentration gradient is going to be set up for drugs and metabolites. So if a drug if something is hydrophobic, has a hydrophobic structure, it's going to be reabsorbed down a concentration gradient. But something that is more polar cannot cross the cell membrane and is going to be excreted. So that takes us back to the purpose of metabolism, turning drugs into more polar entities that can then be easily excreted. And those that are not reabsorbed are just simply going to continue on and go down to the bladder. Okay, and that's how excretion is going to take place. So the role of metabolism is to increase the polarity of drugs so that they can be excreted. Now, quickly here, I glanced through it quickly, but there are many different methods of drug administration, orally, sublingually. You just put the compound under the tongue there. Rectally, you can use the epithelial layer to administer a drug through inhalation, injection, or implants. Now, when we use oral administration, it's the most common route, but the drug has to survive the GI tract, which is when you get to the stomach, is acidic. So the GI tract consists of the mouth, the throat, the stomach, the small intestine, and large intestine. The role of the GI tract is to break down food and absorb nutrient, and it has those strong acidic and digestive enzymes. And when you take in a drug, the GI tract is going to do the same thing to the drug. It's going to break it down. So that drug has to survive the HCl in the stomach. So the capsule or the tablet or the syrup has to be designed in a way to protect the drug from the acid so that it can actually reach its target. So very polar drugs are not very likely to cross the fatty cells, fatty cell membranes that are localized in the GI tract. And when it's the case, you can use those drugs to treat gut infections. Very hydrophobic drugs, though, are poorly absorbed because they dissolve in fat globules from food, and they result in poor surface contact with the gut wall. So they will not actually be absorbed very well. So you have to strike a balance, and there's different other ways to administer drugs that are not fitted for oral administration. You have the respiratory system, for instance, which includes the nose, airways, and lungs. And obviously, the function of the lung is to perform gas exchange, bringing in oxygen, taking out CO2. The alveoli are air sacs with cell membranes. They are surrounded by blood capillaries, and they allow for fast and efficient exchange of gas. And the surface area is 500 square feet, and it can deal with 20 kilograms of air per day. So that's a lot of air there. So when you administer drugs by inhalation, you want to have a drug that's in a volatile type of gas, like the anesthetics, for instance. And you can also have drugs that are in aerosols format, such as the albuterol and salbutamol. You also can administer some of the steroids that way as well. And oftentimes, you want to administer drugs that are going to affect directly the lungs. It is possible to administer those steroids to go in the lungs and help with inflammation and Ventolin that goes to help with asthma as well. Now, some of the drugs that are administered by inhalation can actually cross the fatty layers and get inside of the blood. So some of these drugs can actually access the blood supply. Now, very polar drugs are not very likely to do that. But when drugs are bulkier, as I mentioned, steroids, they can actually get inside of the blood supply. Okay, so you can actually target the lungs if you want to avoid first pass effect, for instance. If you don't want the drug to be broken down by the liver, you can actually target the lungs and deliver the drug to the system that way. Injection, man, as a kid, that was my least favorite route of administration. Grew up in a country where there was a lot of malaria, and every so often I'll get so sick that was the only way to get the medicine in our system and working quickly enough. So I remember my dad always having to tell me, look, you either take the pills, which really didn't taste good at all. You either take the pill or I'll have to give you an injection. And funny story, hydroxychloroquine, that's now in the news currently because of the coronavirus crisis, is one of the drugs that I had to take as a kid. And whoever did the formulation, whoever the pharmaceutical scientist that did the formulation, did a terrible job at it, because the pill was so bitter. You put it in your mouth, it is so bitter. you almost want to take the injection because it felt like it was more painful to take the pill by mouth than to just go for an injection. But anyways, injections always bring fond memories to me. Uh, so these usually drugs that are poorly absorbed orally are injected either you can do subcutaneously or you can do parenterally. Now, once you inject the drug, obviously you can have injection site uh, effects like inflammation or irritation. Those drugs don't have to cross any membranes to get into the blood supply, so you have rapid distribution. There's no first pass effect. And again, this is good and bad. It's good because it gets the effect immediately. It's bad because if it's toxic and if there's too high of a dose, you can take the life of the patient quickly as well. It's more difficult to counter the toxic effects that way. So intravenously through the veins, intramuscularly into the muscle, sub-Q. Oftentimes, when I was working as a pharmacist, we will administer some specific vaccinations subcutaneously because we wanted the vaccination to go in as a depot and then filter through the fatty tissues and distribute slowly in the body. Intrathecal injection into the spinal cord, intraperitoneal injection into the abdominal cavity. I had to undergo that as well as a kid. Anyways, I'm not going to give you all my sad kid stories in this lecture here. Intraocular, never had to deal with that. At least I don't remember having to deal with that, but that's injection into the eye. And the intravenous method has the fastest effect, but it's also the riskiest in terms of toxicity and overdose. Yeah, you can lower the risk by doing an intravenous drip. So the malaria medication that they will give us, they will put us on a drip, and you will sit there, and then for you sit there and they give you the drip, you rest up, then they give you the next dose. It worked really well, but when they didn't dose it right, it was also very, very dangerous, very dangerous. Topical administration, which is my favorite route of administration. It's painless. Um, you can use creams, you can use solutions, and we also have patches that you can use. So the drug is going to cross the skin to reach the blood supply. Now there's an assumption that because it's topical, you don't really get a high dose in the body. That's not true, especially if you're using steroid creams like hydrocortisone. You have to be very careful how much you apply it to the body, because eventually that drug is going to not just affect the skin, but it's going to go inside of the body and get inside of the blood supply. There is no first pass effect, and you can usually use some solvents to aid the absorption of the drug. Now, different parts of the body have different levels of porosities, and chemicals are easily absorbed where the skin is thin. For instance, the forearm. Now, chemicals that are soluble in fat and water are most likely to be absorbed because you have to go through the skin layer. If the skin is moist or wet, that will increase the chances of the chemicals being absorbed. All right, so let's quickly look at blood level concentrations here. So absorption really is what's going to determine the level of concentration inside the maximum blood level concentration inside of the body, and that's going to be determined by the route of administration as well. The concentration shoots up when you administer it, and then it decreases over time. So if you're administering an antibiotic that has to stay in the body for a long period of time, then you have to have a certain, you have to have doses administered at certain intervals to maintain a certain area of over the a certain area under the curve, so that the drug has enough concentration to kill the microorganism. So comparatively speaking, when you have an injection, you have a quick increase in blood level concentrations, and then it levels off over time. Now, let's say that you want the blood levels to remain around here somewhere. So uh, let's say after 4 hours, you administer another dose. Okay. So then that's going to level off again like this. And then you administer another dose. Okay, and that's how you'll be able to maintain the levels of the drug over time here. Let me erase this. Okay, so if you were to take it by inhalation, it will also give you a high increase in the blood levels. So you see, injection and inhalation both will give you a significant blood level concentration. Now, if you took it by mouth, you have less of a peak. You have less of a peak, but if you were to take it dermally on your skin, you even have less of a peak there. So this is to illustrate that blood level concentrations is really going to depend on method of absorption, okay, method of or route of administration. Now there's different drug delivery systems that can be used. A drug can be tied up to a or linked to a polymer, either a synthetic polymer or a protein-based type of polymer, to help with to control how the drug is released inside of the body to avoid spikes of blood concentrations. So instead of the spike that you've seen, the drug will be released and have a over time. Let's say over time, you're gonna have a release of the drug over time. Okay. So some of the ways, some of the linkers that can be used, polyethylene glycol, polyglutamate, and HPMA. You can also do liposomal type of deliveries where you have a drug that is inside of a phospholipid bilayer. Okay, so it's a physical method to protect the drug from enzymes, and the drug is basically encapsulated in a layer of phospholipids, and the drug is encapsulated by sonicating a suspension of phospholipid in an aqueous solution of the drug. Those liposomes have a high drug carrying ability, and then the liposomes are going to be injected, and the drug is going to slowly seep out of the liposome. So not only does it prevent enzymes from breaking down all the drugs at the same time all at once, but it also allows the drug to seep out over time, and it allows for the drug to be released over time. Now, the advantage of this would be the more advantageous way would be to actually target the cells that the liposome is supposed to get near, so that it can have its best effect. Okay, so it avoids those spikes, permits sustained release, but the liposome can concentrate at malignant tumors. And when they concentrate at malignant tumors, they can actually be useful in delivering anti-cancer drugs. As we've seen with some of these anti-cancer drugs, they are effective, but sometimes they affect even good cells. They kill good cells, cells that are rapidly dividing, cells that divide rapidly, such as skin and hair. are also affected. So when you can specifically deliver a liposome containing a drug that's then going to concentrate at malignant tumor and release the drug over time, you can have potential use there in anti-cancer drugs. And again, those liposomes can fuse with plasma membranes, and they can be useful in gene therapy. Obviously, there are some problems with those. It's not always obvious to control the rate of drug release. And even if you have slow leakage, it is dangerous if you have a highly toxic compound, such as the anti-cancer drugs. Now, these liposomes can also be trapped in the reticular endothelial system. There are ways to reduce that being trapped in the reticular endothelial system. So when you attach a polyethylene glycol polymer to the liposome surface, the polymer are going to then act as a polar outer shell. Not only does it protect the liposome from the enzymes, but it's also going to protect it from the endothelial system, from the reticular endothelial system. It increases the half-life or the lifetime of the delivery system, and also decreases drug leakage. A doxyl, for instance, is a pegylated liposome that contains doxorubicin, and it can be used in anti-cancer therapy as a once-a-month infusion. Microsphere are another drug delivery system that can be used. They are constructed of biological degradable polymers. The drug is encapsulated inside. It's going to allow for release of drug over several days or week. It also avoids dose spikes. They're administered by injection. And there's research is ongoing to deliver insulin using microspheres and other peptide-based drugs. All right, thank you so much for taking the time to watch this lecture or listen to it, and I hope you have a good rest of the day.